Greetings, everyone, joining with us from around the world. I am Dr. Fatima Begum, Head Thyroid Division, National Institute of Nuclear Medicine and Allied Sciences, Bangladesh Atomic Energy Commission. Welcome you all to this thyroid cancer session of 15th International Conference on Radiopharmaceutical Therapy. I am really humbled to chair this session. We all know about the successful story of radioiodine therapy on thyroid cancer for more than 7 decades. Still, guidelines for radioiodine therapy are ever evolving with ongoing new research. Sometimes we face difficulties to treat complicated cases following particular guidelines. We will hear more from today's expert. I hope you will be with us throughout this informative session. I would like to add, if you have questions or comments, please direct them to the chat box. There will be question and answer session at the end of the day. Without further ado, let's start the session. We have with us today our first speaker, Professor Henry Hee-Seng Bom. He is currently the Professor of Nuclear Medicine at the Cheonnam National University Medical School and Hospital, Gwangju, South Korea, and the Chairman of the Asian Regional Cooperative Council for Nuclear Medicine. Aside from holding several important positions throughout his life, he has published almost 300 peer-reviewed papers and 22 book chapters. His research interests focus on radioiodine therapy for thyroid cancer and cardiac hybrid imaging. Recently, he has been appointed as Editor-in-Chief of Nuclear Medicine and Molecular Imaging, which is the official journal of Korean Society of Nuclear Medicine. He will be in charge from January 2021. Professor Bom will be speaking about new Korean protocol of radioiodine therapy. Welcome, Professor Bom. Our second speaker for today's session is Dr. Savvas Frangos. He works as a nuclear medicine specialist in the Nuclear Medicine Department and Thyroid Cancer Unit at Bank of Cyprus Oncology Center, Nicosia, Cyprus. Dr. Frangos is the Secretary-Treasurer, European Union of Medical Specialists Section, Nuclear Medicine, Treasurer-elect, and National Delegate of Cyprus of World Federation of Nuclear Medicine and Biology, also the National Delegate of Cyprus at European Association of Nuclear Medicine. He is member of governing body of World Association of Radiopharmaceutical and Molecular Therapy, and member of many national medical associations. Dr. Frangos will be delivering his speech on applying thyroid cancer guidelines, difficult task. Welcome, Dr. Frangos. Our last speaker of the session will be Dr. Partha S. Choudhary. He is the Director of Nuclear Medicine at the Rajiv Gandhi Cancer Institute, New Delhi, India. He is also currently the President-elect of World Association of Radiopharmaceutical and Molecular Therapy and member of Board of Directors, Asia-Oceania Federation of Nuclear Medicine and Biology. Dr. Choudhary is an internationally acclaimed leading nuclear medicine physician of India with special interest in radionuclear therapy of various types of cancers. He has more than 25 years of experience in nuclear oncology and has achieved numerous awards and positions throughout his career. Dr. Choudhary will be presenting on management of refractory DTC. Welcome, Dr. Choudhary. Thank you all for your kind presence in this session. Thank you.
Dear colleagues, ladies and gentlemen, nice to meet you. I'm Professor Henry Bom of South Korea, President of Korea Thyroid Association, and Chairman of the Asian Regional Cooperative Council for Nuclear Medicine. I deeply appreciate organizers for their endeavor making this virtual conference and inviting me to present here. It's my great pleasure and honor to introduce new Korean protocol of radioactive iodine therapy. This protocol is not a guideline. It's a changing trend of our versatile therapeutic tool. I have no conflict of interest for this presentation. What I introduce in this presentation can be summarized by 3 words: recombinant human TSH stimulation, low-dose therapy, and stepwise approach. This slide shows a dramatic change of stimulation method. In other words, a rapid increase of recombinant TSH or thyrogen stimulation method. The growth started from 2011, showed a big jump, and reached plateau in 2015. Now, 90% of radioiodine therapy is done after thyrogen injection. Use of low-dose radioiodine therapy showed the same trend, peaked in 2016. Now, 70% of radioiodine therapy in Korea is using low dose. What made this dramatic change? 2 well-known papers published on the New England Journal of Medicine in 2012 was the trigger. Estimable paper by Schlumberger et al. Showed no difference of thyroid ablation between low-dose and high-dose groups and between thyroid hormone withdrawal and thyrogen injection groups. High-low study by Malik et al. Also compared the low versus high-dose and thyroid withdrawal versus thyrogen injection groups. There was no difference between both 2 groups. The summary of messages from estimable and high-low trials is that there is no difference of ablation rates between low and high doses and between thyroid hormone withdrawal and recombinant human TSH or thyrogen injection groups. Estimable and high-low trials resulted in change of guidelines. American Thyroid Association published new guideline in 2015. Next year, in 2016, the Korea Thyroid Association published new guideline, the context of which was a little bit different, but similarly agreed use of low dose and thyrogen injection. After publication of estimable and high-low papers, physicians prescribe low dose and thyrogen, as you see in these graphs. In patients with T1A and 0 or NX, no radioiodine treatment is recommended. Patients with T1B to T2 and 0 NX and N1 micro, we recommend 30 millicuries with thyrogen injection. Those with T3 larger than 4 cm, any N than 100 millicuries, also with thyrogen injection. In case of T4, N1 macro, and distal metastasis, so then it's a 100 millicuries or more, but we recommend thyroid hormone withdrawal rather than thyrogen injection. These recommendations significantly changed the protocol of radioiodine therapy in Korea. Now, we use mainly thyrogen and low dose. If the trend is lowering dose, we have a question. How low is low? As you know, the borderline of low and high dose is 100 millicuries. Dr. Zinat Jabin of Bangladesh and I surveyed on the radioiodine therapy in 2016 after the new guidelines came. We wanted to know how nuclear medicine physicians in Asia prescribe radiotherapy dose. And what's the reason? Total of 38 institutes from 19 countries throughout Asia participated. According to the survey, dose selection was heterogeneous, but there was a trend. They chose no treatment or low dose only in low risk group. In intermediate risk group, they used either low or high doses, and in high risk group, they used high dose only. This graph shows dose selection patterns in Korea in 2009 and 2019, 10 years apart. In 2009, before the guideline, low dose means only 30 millicuries, and high dose means 150 or more. Now, low doses include any dose below 100, such as 30, 35, 40, 50, or 80. High dose include usually 100 and only small number of 150 or 200. We analyzed the reasons why physicians choose different doses and published the result on nuclear medicine communications in 2018. There are several clinical social factors which physicians consider for the dose selection. Physicians usually escalate the dose when patient's serum thyroglobulin level is high, when they got inadequate information on lymph node involvement, if there is a limitation in histopathology reporting, if patient's compliance is poor, if there is fewer facilities for regular follow-up, and if there is no health insurance support. Nowadays, many Korean physicians choose low dose first and then do iodine 1 to 3 scan after 6 months, and then decide either continue thyroid hormone replacement or repeat radioiodine therapy. They usually choose high dose for the second therapy. This is a more complex flow chart of radioiodine therapy. Let's see in detail. If differentiated thyroid cancer is detected, if it is low risk, especially in microcarcinoma, we do lobectomy or active surveillance. While those with higher risk, we do total thyroidectomy. After total thyroidectomy and pathological staging, when patient's serum thyroglobulin is undetectable, we do thyroid hormone replacement therapy. If there is distant metastasis, we may consider dosimetry-based maximum permissible dose therapy. Patients with detectable thyroglobulin but no distant metastasis, we usually do low dose radiation therapy. We do post-therapy whole body scan and follow-up exams after 6 months. If response is complete response, then we do thyroid hormone replace. If it is partial response, stable disease, or progressive disease, we apply second radiation therapy, usually with a high dose. In summary, ladies and gentlemen, I introduced in this presentation 3 keywords of recent change of protocols of radiation therapy in Korea. Those are recombinant human TSH or thyrogen injection, low-dose radiation therapy, and stepwise approach. I really miss colleagues of warmth. I miss Bangladesh, especially the beautiful long beach of Cox's Bazar and city of Dhaka. I hope to see you face to face soon again. Thank you very much for your kind attention.
Hello to everybody. My name is Savvas Frangos, and I will talk about applying thyroid cancer guidelines, a very difficult task. I have nothing to declare, and my country is Cyprus, very difficult to be seen in this world map. That's why I put it also in a bigger map. This is the shape of my island, Cyprus. My connection to warmth start when Harvey Turner from Australia, the founder and president of the World Radiopharmaceutical Therapy Council, has the inspiration of the new name of the organization, WORM, which was a dream of Professor Ajit Pai. And I was there forming the constitution of the WORM, which was approved by the General Assembly of the WRTC in 4th of November. And I was active participating when it was approved and adopted by the first General Assembly of WORMS, which was held 7th of November at Cartagena, Colombia. Australian inspiration of the logo by Harvey Turner is that the map behind the signal of radioactivity is Australia in the middle. My connection to WORMS also is regarding the redesign of WORMS logo and the creation of the new ICRT WTA logos, which have been done in Cyprus, part with my ideas. Any similarities are in purpose. Here is Curium Theatre during the ICRT, the first ICRT in Cyprus, and here is the ICRT logo. After Ajit Pai left the agency, all of us were thinking this effort without the support of EIA will stop. Once again, all of us were wrong. He started with the International Conference on Radionuclide Therapy without budget, without any money back in 2005. We organized together the first meeting in Cyprus. That was 15 years ago, and nobody at that time believed that this ICRT will continue over the years. Applying thyroid cancer guideline is like this traffic sign. There are 3 different traffic signs on one, and then you don't know exactly what to do. This is the Bank of Cyprus Oncology Center, where I am working every day. And my presentation outline is about etymology, comparing guidelines, the other guidelines, the ENM guidelines, example of applying or not applying the guidelines, why ENM declined to endorse ADA 2015, the Martinique principle, and where should the guideline be applied. What are guidelines? Information intended to advise people on how something should be done or what something should be. And what are clinical practice guidelines? Systematically developed statements to assist practitioners and patient decisions about appropriate healthcare for specific clinical circumstances. And where is the problem now to applying thyroid cancer guideline? There are too many. And if there are too many, that means there are also too many different opinions. What is the primary therapy for thyroid cancer? Is to remove the primary tumor, including lymph node metastasis, and the completeness of the surgery is the most important factor influencing the prognosis of each patient. Radioiodine treatment and TSH suppression play in most of the case an adjuvant role. Here is the ADA 2050 guidelines, and here is the ENM guidelines. What are the differences? The date of publishing, 2050 for ADA and 2008 for ENM. And what about nodules? ADA is evaluate general nodules, they are more than 1 centimeter, but ENM is not dealing with nodules. What about ablation therapy? ADA suggests in selective cases, if the tumor is larger than 4 centimeters with lymph node involvement, And A&M insists to use iodine 131 ablation therapy in all cases with cancer except less than 1 centimeter without risk factors. The clinical practice guidelines are to assist practitioners. And this led also in one editorial in the European Journal of Nuclear Medicine, one should not just read what one believes. And the conclusion was, before applying thyroid cancer management to everyday practice, the clinician should be aware that recommendation not infrequently suffer from their authors reading what they believe instead of believing what they read. And this is also, say, in this Japanese proverb. I'm sure that almost everybody speaks Japanese, but in case that someone is not speaking, it say, if you believe everything you read, better not read. In another research article about systematic review of clinical practice guideline about thyroid cancer, the summary was that the current clinical practice guideline varied in methodological quality and increased effort are required to improve the quality of recommendation. Ablation therapy, different guidelines, different approach. This is what we wanted to show in one of our articles that we published in the European Journal of Nuclear Medicine. There were two centers, our center in Cyprus and another one, big center in Greece, and we enrolled 336 patients with T1 and T2 status, and about 20% of the patients, they have also lymph node involvement. The thyroglobulin level was on those patients only in 10% in Cyprus and 4% in Greece, less than 1 nanogram per milliliter. But please notice that in about 20% in Cyprus and 12.3% in Greece were more than 10 nanogram per milliliter. And if you notice, the thyroglobulin antibodies were positive in Cyprus in about 42% and in Greece about 32%, which is much more than the average of the rest of the world. If we were applying the ATA guidelines, there were 130 no indication and 110 indication. If we are moving to NCCN, then the number of no indication reduced to 86. And if we are going further to EANM, the no indication number was 65 and the indication was for 237 patients. In the same time that we published our data, it was also published the new ATA guideline 2015, and we wanted to see if these two guidelines are fighting each other, which will be the winner. That means we enroll the same number of patients using, in this case, the ATA 2015 versus ATA 2009. This is the slide that I showed before for 2009. 130, they have no indication, 96 recommendation, and 110 indication. And then we wanted to see now the new situation. 100 out of 336 patients changed classification regarding indication for ablation if we are using ATA 2015 instead of 2009. Most reclassified patients move from no indication or clear indication to possible indication. Reflecting this phenomenon, possible indication became the larger category according to ATA 2015. These are the numbers, what I mentioned before. And regarding the specific issue of indication for ablation, we believe that the latest ATA guideline, 2015, should be commended for better acknowledging gray areas that did the earlier edition. And we conclude writing that applying the guideline is rather art than science. And this was taken by my friend Verburg Luster, and Giovanella, that they wrote an editorial if adjuvant post-operative iodine-131 therapy for thyroid cancer are guidelines an exact science or a dark art. Let's see applying the guideline to real patient. I choose one patient from our clinic, female 84, evaluate for lymphadenopathy, and they found incidentally a 5 millimeter thyroid node. What to do? We can follow the road of real world or the guidelines. According to the guideline, less than 1 centimeter should not be further evaluated. What we have done, we perform a fine needle aspiration. The reason was more the peripheral location of the nodule, possible of extrathyroid extension rather than the suspicious feature. Then there came the FNA biopsy, which show a type 5 results. Should we operate? Of course, if we have positive, then we should operate, but which operation? The ADA 2015 is recommended thyroid lobectomy. And the advantage of total thyroidectomy are there and ignored from the guideline, because a high rate of occult cancer in about 60% in the contralateral lobe in papillary cancer. Another major advantage of total thyroidectomy is the use of radioiodine scan to facilitate detection of metastatic disease. That's why we perform total thyroidectomy. Shall we do a neck dissection? According to ADA 2015, thyroid prophylactic central neck dissection is not appropriate for small cancer. But we perform also lymph node dissection, removing 17 lymph nodes. The histopathology show a pure papillary carcinoma of the left lobe. The 17 lymph nodes were negative. This was given as T3, stage 3, because of the age of the patient at that time. Now is stage 1. But according to the definition of T3, the tumor should have, if they have minimal extrathyroid extension, then should be T1A. To ablate or not to ablate, according to ADA 2015, then should not be any ablation in this patient. And these are shown in these slides. According to ENM, also should not be applied. But according to our, in addition to standard clinical pathological feature, local factor should be also taken in consideration. Quality of preoperative US evaluation was excellent. The quality of postoperative US evaluation is not done. The thyroglobulin measurement showed 3.5 nanogram with negative antibodies, and the surgeon was an experienced UK-educated endocrine surgeon. We perform also an ablation therapy with 3,700 megabecquerel iodine 131, and this is the post-therapy scan. You can see obviously there are also increased uptake in some lymph nodes. Here is the SPECT, and here is the comparison. According to the guidelines, we should not do any further evaluation. We perform FNA and it was type 5. According to the guideline, it should not be a lobectomy. Then we perform a thyroidectomy. No neck dissection, we make neck dissection. No ablation therapy, we perform ablation therapy, and this was for the benefit of the patient. 1 year later, we performed this whole body scan and everything was fine. This is just one example. If you are hearing clopping sound, most of the time it's a horse but sometimes is a zebra. Let's moving now why the European Association of Nuclear Medicine declined to endorse the ATA 2015. One of the main factors was that ENM was never consulted during the creation of the guideline. The proposal for radical changes to therapeutical strategy is, according to our opinion, not based in a solid body of evidence. And the ENM is still of the opinion that iodine-131 therapy is a beneficial adjuvant therapy in most or all patients with a thyroid cancer bigger than 1 centimeter in diameter. The ENM board will, however, very much like to offer the American Thyroid Association the benefit of our association expertise for further guidelines. And this led to Martinique, another one island, much smaller than Cyprus. You cannot see it in the world map, that we have to increase. What happened in Martinique? Various individuals of the ATA, ENM, SNMMI, and the European Thyroid Association, they discussed differences in the opinion regarding the management of thyroid cancer. There were a lot of principles. I'm not going to all of them because of the lack of the time. In the principle 3, patient demonstrating no histological, biochemical, or imaging evidence of persistent disease after appropriate initial surgery may be candidates for observation, remnant ablation, or adjuvant treatment. And in 5, in thyroid cancer, they are most likely is not one right way of treating patients. And to make the whole thing much more complicated, often the final decision on whether to give iodine-131 is influenced by patient wishes, objection, hopes, and fear. And finishing, it is assumed that higher administered iodine-131 will on average lead to greater therapeutical efficiency by delivering higher absorbed dose to target lesion. At the same time, the absorbed dose to non-target tissues, such as the salivary glands, will also create increasing administrative activity. That's potentially leading to a higher incidence of adverse effects such as sialadenitis. Assessing the role of adjuvant treatment by review of the literature is difficult. In low-risk patients, the issue may not be the effectiveness of the therapy, but rather a relative small number of low-risk patients who truly have residual disease. And the decision should be on an individual basis in a multidisciplinary setting. Where should be the guideline applied? In utopia. It's a community of society possessing highly desirable or near perfect quality. In this utopia, they have the most experienced surgeons, pathologists with the best eyes, patients without autoantibodies, and the best nuclear medicine specialists. Thank you very much. Ευχαριστώ πολύ.
Hello, friends of warmth. So I'm here today to give my presentation on the management of I-131 refractory thyroid cancer. And this is a multimodality approach. My name is Partha Choudhary. I work in Rajiv Gandhi Cancer Institute and Research Center in New Delhi. That's my hospital. And I am currently the president of Warmth. I have nothing to declare. So coming to the prognostic indicators in thyroid cancer, as we know that we have few scores like the AG score and the Macy score. The AG score is doing with age, histological grade, extrathyroidal invasion, and metastases, where the Macy score is mostly on the post-operative setting, where we look about distant metastases, age, most important, completeness of the original resection, extrathyroidal invasion, and the size of the original lesion to create the prognostic factors later. So talking about the thyroid cancer subtypes, the most prevalent is the papillary thyroid cancer, which accounts for about 85 to 90%, and it represents the most common variety. The next in line is the follicular cancer, which accounts for about 10 to 15% of the subtypes, and again, it's a well-differentiated tumor. The least common varieties are medullary CA thyroid and the anaplastic cancer of the thyroid, which accounts for 5% and 1% respectively. However, today we are going to talk mostly only about the differentiated thyroid cancer or the dedifferentiated thyroid cancer, and not touch about medullary or anaplastic thyroid cancer. So this, told you before, it represents 90% of all thyroid malignancies. It's a multimodality therapeutic approach. It is risk adapted to achieve optimal treatment and to minimize treatment-related morbidity. And the treatment in line of preference includes, first, the surgery, which could be either near or total thyroidectomy, followed by remnant ablation using radioactive iodine. And following this, we do a risk stratified follow-up, including hormone substitution and other treatment as and when required. So this is the staging of thyroid cancer. And unlike other malignancies where we have a TNM staging, the differentiated thyroid cancers are staged in a slightly different way. And age is one of the most important factors when we are staging thyroid cancer. So when we talk of a patient of thyroid cancer who is 45 years or younger, we have only two stages of thyroid cancer, stage 1 and stage 2. Stage 1 meaning any size tumor located in the thyroid, or it can spread to local lymph nodes and tissues. And the stage 2 is whether it has spread to any parts of the body apart from the size of the tumor. The stage changes when we are dealing with a patient who is 45 years, more than 45 years rather, and then we have 4 stages. So the size of the nodule also plays an important factor. So stage 1 is 2 centimeters or smaller, located in the thyroid. And when we go to stage 3, it's a tumor larger than 4 centimeters and only in the thyroid, or tumor of any size spreading outside the thyroid but not the lymph nodes, or to the lymph nodes and the adjacent structures like the trachea or the larynx. And stage 4 subdivided into stage 4A, B, and C, spreading to other parts of the body. So based on that, the risk stratification we define as a low-risk group where men of 40 years and younger, women of 50 years and younger without distant metastases, and all older patients with intrathyroidal papillary carcinoma or follicular carcinoma with microcapsular involvement and tumors less than 5 centimeters in diameter, no distant metastases. The high-risk group consists of patients with distant metastases and all older patients with extrathyroid papillary carcinoma or follicular carcinoma with major capsular involvement and with tumors 5 centimeters or larger, regardless of the extent of disease. And this risk stratification goes a long way in predicting the outcomes in differentiated thyroid cancer. The goals of initial treatment, first is the removal of primary tumor, all extracapsular disease and the involved lymph nodes, facilitate post-operative radioactive iodine treatment, and one of the primary goals later is to minimize disease recurrence and metastatic spread, where the initial surgery is the most important factor influencing the prognosis. So therefore, the initial treatment of surgery goes a long way in predicting or evaluating the patient's outcome. That's why many times we say that the head and neck surgeon is one of the prognostic indicators in differentiated thyroid cancer. So as far as the initial treatment is concerned, it could be either, as I said before, near or total thyroidectomy, It should be individualized based on your particular protocols. Stage the tumor, risk stratify, do radioactive iodine remnant ablation or radioactive iodine treatment, and follow up, which can be a short term or a long term follow up. So, this is depicted in a graphical way. The whole gamut of management in differentiated thyroid cancers, where first, as I said, the initial treatment is surgery, and when progression, oligoprogression, can go back to surgery. So the first risk stratification includes surgical pathology, lymph node and surrounding tissue involvement, and post-op thyroglobulin level, divided into then later low risk, intermediate risk, and high risk. So we are not going to talk about all these now. We will straight away jump to the dedifferentiated thyroid cancer, where we have other modalities of treatment. So there could be the tyrosine kinase inhibitors, the BRF inhibitors, or in clinical trials, RET inhibitors, and even immunotherapy. So this is a study which looked into 444 patients of advanced differentiated thyroid cancer, and it clearly showed that the outcome was dependent on how much radioiodine treatment responsive were the patients. So where in 68% of these patients were radioactive iodine responsive, a 10-year survival rate of 92% was reported. And 32% of these were radioactive iodine refractory, and the 10-year survival rate dropped to 10%. So therefore, there is variability in natural history, even within this subset of differentiated thyroid cancer. So coming to the topic in particular, talking about thyroid cancer beyond radioiodine. So if we have a definition of what is thyroid cancer beyond radioiodine, first, it is a metastatic disease not taking up I-131 at the time of initial treatment. The tumors losing the ability to take up radioiodine after previous evidence of uptake. I-131 concentration in some lesions, but not others. And there could be a progressive disease despite substantial radioactive iodine uptake. So therefore, in advanced differentiated thyroid cancer, generally, the workup is slightly different. Some other investigations are added. So main principle of investigating this group of patients is to identify clinically relevant sites of disease. We have to have an imaging modality which can assess serially the progression or response. We need to assess the need for additional local intervention, for example, external beam radiation, excision, RFA, etc., depending on how much is the disease burden, and an imaging modality which can accurately say the response to targeted treatments. And these targeted treatments are inhibitors of oncogenic signaling pathways, modulators of growth, or apoptosis, or TKI inhibitors. So coming from the imaging point of view, earlier it used to be mostly the radioactive iodine whole body scan or the thyroid scan, but there has been a paradigm shift in imaging, and few other imaging modalities has been added, as I said. So first of all, the role of FDG PET has come in a big way. So the most common indication of FDG in differentiated thyroid cancer is in the elevated thyroglobulin and a negative I-131 scan, which we commonly call as the Tennis syndrome. There could be a gradual differentiation with activation of cellular glucose metabolism, which can be imaged by both the imaging modalities. What we talk about, a flip-flop phenomenon like iodine positive, glucose negative, or vice versa, this is not absolute. So it could be either or overlapping each other. So with FDG PET, if we look into the literature, the sensitivity of disease detection is almost to the tune of 70 to 90%. And what is more important is, depending on a specific clinical setting, it may affect the patient management in 20 to 40%, which is a big percentage as far as the treatment is concerned. Do we have any role of FDG PET in initial staging? Yes, the literature is there with few studies showing that in high-risk patients, advanced T-stage, distant metastases, and at diagnosis or aggressive histological subtypes, there is certainly a role of FDG PET in initial staging. And there can be areas which frequently do not show radioiodine concentration post-surgery, and these areas may not benefit from I-131 therapy. So we need to identify these sites which will need other modalities of treatment. This is again a 90 patients data where FDG PET has been analyzed in this setting. And of course, during the first post-therapy scan, if FDG PET was performed to see the extent of disease and its impact on management, there were 29% FDG positive lesions. And it impacted the management in 21% and provided very good prognostic information. So therefore, the prognostic significance will be in metastatic differentiated thyroid cancer with high FDG uptake. So these will be mostly dedifferentiated, aggressive variety of tumor resulting in poor prognosis and reduced survival. And various quantification methods can be used to risk stratify these group of patients, which could be a metabolic tumor volume, SUV max, number of metastatic sites, all can predict the outcome in patients. Total volume of FDG positive disease is the strongest prognostic indicator of survival. In high-risk DTC, age and FDG are strong survival predictors in multivariate analysis. And of course, negative PET scan in the tennis syndrome, where the glucose metabolism in the disease may not be to that extent, suppression by thyroxine is adequate, which the few studies have shown. And of course, negative FDG with high I-131, we know has a much better prognosis than the other way around. So therefore, when we come to dedifferentiated thyroid cancer, do all patients need treatment, or we have a particular group which would actually be treated? So therefore, treatment must be instituted. First, symptomatic disease, and second, bulky disease. Where disease is non-measurable, like response evaluation may be difficult, like pleural involvement, bone metastases, or in local treatment like surgery, external beam, or RFA. So depending on the number of lesions, depending on the site of disease, a different type of treatment needs to be instituted. So one of a typical example of a tennis syndrome, this is a patient of papillary thyroid, and if you can see in the first follow-up, in the iodine scan, there is total ablation with a high TG level, and FDG PET scan shows a lesion in the thyroid bed. So this is a single site of disease which could be treated by a local modality. It could either be surgery, if it's amenable to surgery, it could be radiofrequency ablation or radiation treatment. So, but all the same, if this lesion is amenable to surgery, the surgery is the first option, and the patient can become disease-free. Rate of progression is important. Do we need to treat patients all who have disease? Or depending on the type of tumor and the rate of progression, the tumor doubling time is also important. So there have been two trials. One is the SELECT and the DECISION trials, which required progression by RECIST, more than 20% increase in 13 and 14 months, and other clinical parameters were also taken into account. They found that the tumor doubling time provides useful prognostic information and also predicts survival. The second trial was the DECISION trial, which was randomized phase 3 trial of sorafenib versus the placebo. Again, the eligibility was radioiodine refractory differentiated thyroid cancer, having progressive disease within 14 months, no prior chemotherapy or tyrosine kinase inhibitors. Two groups of patients, sorafenib versus the placebo. There could be unblinding upon progression. Crossover of placebo to sorafenib was allowed, and patients were followed up till progression. And the primary endpoint was progression-free survival. So what we got in the decision trial, the survival endpoints was there was significant difference in progression-free survival between sorafenib and placebo. The response rate of 12%, and there has been no complete response. The median overall survival is more than 2 years, and there was no difference in two arms. However, there was a crossover of 71%. The second trial was a global randomized double-blind phase 3 trial of lenvatinib called the SELECT trial, which included 392 patients and radioiodine refractory and measurable disease, stratified, and one group given lenvatinib 24 milligram daily in 261 patients, and placebo given to 131 patients 24 milligram daily, crossover optional at progression. So the primary endpoint was progression-free survival, and the secondary endpoints were overall response rate, overall survival, and safety. So this was the SELECT trial results, where the median progression-free survival was 18.3 months versus 3.6 months in placebo, with an overall response rate of 65%, clearly showing that lenvatinib actually had a good response rate in radioiodine refractory thyroid cancer. The good response rate comes along with side effects as well, which impacts the quality of life to a great extent. There are many patients who are unable to tolerate the full dose of lenvatinib. Most common side effects were hypertension in 42%, which was more than grade 3. There was diarrhea, fatigue, weight loss, nausea, stomatitis, hand and foot syndrome. So 82% patients had to hold dose, 68% had dose reductions to 17 milligram per day, 14% had permanent discontinuation of treatment. So this is a slide showing a recurrence of papillary CA, which is FDG positive, and diffuse disease showing extensive lung metastases and a thyroid operative bed lesion. So we are more concerned also with evolving dedifferentiation. This is an entity which we mostly see in our practice these days, that a tumor which has been radioiodine amenable initially, gradually over a period of time starts dedifferentiating and becomes FDG or GLUT receptor positive. So this is one of the cases where if you can see the brain metastases, which is still iodine avid and can be treated with radioactive iodine, when you do an FDG PET scan, it doesn't concentrate FDG, meaning that it is still differentiated tumor. But if you look into the bone metastases and the lung metastases, they're much more prominent in the FDG study, meaning that they would require other modalities of treatment, mostly TKI, tyrosine kinase inhibitors for treatment. Another side of the story where, as I said, advanced disease as presentation, there could be coexisting radioiodine positive and refractory disease, mostly in mutation study positive patients. So this is an iodine scan which shows good, bulky iodine positive disease. At the same time, there are same lesions which could be FDG positive as well as other FDG positive lesions as well. So this patient again needs a multimodality management. So this is again other side of the coin, where one side we showed an evolving dedifferentiation, the other side is iodine refractory straight away to begin with, that is intra-patient tumor heterogeneity. So response evaluation can very well be done with FDG scans. If we see here, the iodine scans and the FDG scans, where the response evaluation post lenvatinib has been done, which shows a partial response. So coming to other imaging modalities or other imaging radiopharmaceuticals as far as iodine refractory disease is concerned, in literature, somatostatin receptor imaging has been found useful in a subset of I-131 non-avid metastatic disease, and these patients have become amenable to treatment with PRRT with 177 lutetium dotatate. Whereas I don't have personal experience in treating different dedifferentiated thyroid cancer with lutetium dotatate, but there are some centers, 1 or 2 centers in India, which have done few cases of such variety. And this is one such case from my colleague, which shows that this lesion in the lungs can concentrate lutetium dotatate, and it's amenable to treatment with PRRT. So this is one review article which we have put down all our thoughts from this is in the British Journal of Radiology 2 years back. If you're interested, you can go through it, where we have clearly said that in high-risk patients for precise treatment planning, we will need other radiopharmaceuticals like dotatate and other radiopharmaceuticals for imaging and possible treatment of dedifferentiated thyroid cancer. So there are other investigational therapeutic approaches, choosing appropriate therapy. For example, as I said, SSTR-based imaging, if there are receptor-based lesions in stable metastatic disease or progressive metastatic disease, we can continue PRRT with lutetium dotatate. Molecular targeted treatment with TKI, whether progressive or symptomatic metastatic disease with good PS, sorafenib and envatinib are currently approved. So this is one of the important treatment modalities in dedifferentiated thyroid cancers. People have talked about redifferentiation agents, chemotherapy, but we certainly have insufficient evidence in this group. So to summarize, differentiated thyroid cancer is a rare tumor entity. The therapeutic approach, including surgery and remnant ablation with radioiodine, is most commonly followed. The lifespan of most differentiated thyroid cancer patients does not differ from general population when appropriate treatment is given. And current guidelines of American Thyroid Association and EANM, there is no evidence-based treatment concept or strong recommendation for every situation. There has been different levels of recommendation for each situation. Although in the current guidelines, no explicit recommendation concerning the determination of molecular markers in the cytological or histopathological specimen is made, further adjustments are to be expected in the future, depending on how the tumor evolves and how the tumor heterogeneity evolves. Mostly asymptomatic patients are seen in dedifferentiated thyroid cancer, so there is a big clinical dilemma. It can mostly be seen, as we see now, in mostly high-risk group of differentiated thyroid cancer. As I said before, FDG PET has a crucial role in detection. Surgery, primary therapy modality, if possible. And there is a clearly an evolving role of gallium-68 DOTA scan in this group, followed by lutetium PRRT if it is feasible. So what do we carry home? In advanced radioiodine refractory differentiated thyroid cancer, the TKI offers durable response in most patients, including all histopathological types, all metastatic types, and even in elderly patients. The progression-free survival benefit is durable, and response is usually long-lasting, but side effects require good management to continue these TKI treatment in dedifferentiated thyroid cancer for a long time. Thank you, ladies and gentlemen.